sure. Computer 3D modeling.
Okay, I think we can probably begin now. I think we've
Yeah.
waited it enough and people are not holding in anymore. So, hello everyone. I'm Don. I'm a fourth year. I'm the president of Pro Study Club. I'm sure Dr. Yu doesn't need an introduction. I'm sure every single one of you know who he is. So he'll be talking to us today about digital dentistry, how to incorporate CAD/CAM scanning in clinic if you're first year, second year, when you enter clinic, you can actually mill restorations in clinic now. And he's going to go through the workflow for that. And also he'll just talk about how to incorporate digital dentistry in private practice in general. So yeah, thank you for being here. And I think we can get started now with the lecture. Dr. Yu.
All right, thank you, Don, and thank you for the invitation. So I figured that people are still wrapping up with clinic and everything, so people are gonna like slowly roll in. So as you guys begin, you haven't already done so, please look at the top of the screen and just go to menti.com. It's where we're just playing a quick kind of audience interaction. Type in the code, and then it's gonna ask you same question down here. Type in the first word that comes into your mind. I'm trying to play a little word cloud here as we're waiting for more people. I'm just gonna wait until we have 20 responses. I'm gonna pause it and we're gonna go on, okay? That's good. Doesn't like any. All right, gonna kill it here. So a lot of positive words, a lot of positive vibes here. Happy patients, efficiency, I like to hear that too. Expensive, yes, it is expensive, and amazing, very good. Futuristic, all of that is correct. All right, so I'm actually gonna switch gear here and share with you the actual presentation. Let's see. So today I thought we're going to just talk about adopting the digital workflow in dental school and beyond. And the beyond part is actually targeting as if whether you're going to be a prosthodontist, a specialist down the line, or just a general dentist. I think digital dentistry will apply to all disciplines at this point. There's usually nobody who can run away from digital technology nowadays if you're practicing dentistry. So we'll talk about the general pointers, and this is supposed to be more of a superficial kind of lecture, but if you have any questions or concerns, feel free to email me or contact me afterwards too. I'll try to help you. So whenever we say, let's go digital, let's adopt the digital workflow, your initial reaction, just like the word cloud is showing, is a lot of excitement, right? And we're going into the future. Actually, it's not the future anymore. It's kind of pretty much the present. A lot of dental labs and dental practices are starting to adopt that digital workflow in one way or another. And there's a lot of excitement coming from the patient, from the practitioners. But when you start thinking about the technology part of it, when you have different type of scanners available, different type of technologies, 3D printers, mills and whatnot, it gets a little bit more mind-boggling. And if you're just a general practitioner or just coming out of school and starting to look into setting up your own digital workflow for the first time, it must be kind of nervous and probably mind-boggling too, right? So hopefully what we have today will start to thinking about the process. And I didn't go into a lot of details about the kind of nooks and crannies about prices and whatnot about adopting a digital workflow, but we want to talk about why we want to consider adopting a workflow, or why not. In certain cases, might not be a good choice. And what is the right applications for you? Because we know that digital technology can allows you to do a lot of things, from smile design to implant workflow to all the way to CAD/CAM to even orthodontics, right? You, depending on your specialty, depending on your practice, you might have to choose the right applications for you, right? And then figure out the game plan. And that part, we're gonna start from what we're gonna do in school and talk a little bit about what you can do outside. How do you kind of start adopting and changing your practice? So first of all, dentistry itself is no stranger to digital technology. This might be new to you, but back in the days when I was in school, we were still using paper charts. So I think it was kind of when I was about to graduate, that's 2010, when we started migrating to a digital system. And then they migrated over to Axiom. So the transition from the chart, basically transition to a chartless office, is a big thing back in 2010, because there was a state mandate, or actually a national mandate, that requires all medical and dental offices to go chartless. So everything has to switch from the physical records to digital form. And usually those softwares also contains patient management software as well. So it's a good place where you fall in all the patient's records. It's an easier transition. However, it usually takes about 12 to 18 months for this whole transition to take place. And not to even mention the cost of it. I mean, the cost of it is just a software essentially, but the process of transitioning everything, scanning all the paperwork and transition them over into a digital format is gonna take a lot of time, right? And then we have the digital radiographs. And then again, tracing back to about 10, 15 years ago, when I was in school, we were still using traditional films, and we're still using those developers. All our scrubs were kind of having, I think all our scrubs had those those developer stains. Is a thing of the past now. As you know, like we have all the digital now. You can basically incorporate everything, can be sent out in the X-ray image or in the JPEG format, and you can send it to the next office easily from one office to another, right? And the whole equipment setup with the software is usually about $15,000 to do this, but still, it's a reasonable cost, because if you're setting up a new office, you definitely want to have digital X-rays, right? Then we have intraoral cameras, right? Intraoral cameras, which is basically a small head camera that are able to scan your teeth and take a photo of your teeth, which about 5-10 years ago, that's a new thing, a revolutionary thing, where the patients are able to see the restoration, what's the crack, what's the cavity, and that's a really good way of convincing the patient to accept the treatment plan. And that costs actually, if depending on the quality of the camera, you can get a really cheap one for $50, a really good one for around $500, or is slightly more. But the adoption is very easy, especially if you already have the digital X-ray system. Usually that will be as part of the X-ray or X-ray image, where you can basically just upload a picture into that system, and that becomes part of the patient's records. So the idea is that, believe it or not, you are already immersed in the pretty digital dental ecosystem in your everyday practice. And it shouldn't take, it's not a super high threshold for you to take the next step, which is to commit to the intraoral scanning and then all the current applications of digital dentistry. And we're going to quickly go over that and focus a little bit more on restorative and prosthodontics, since we're talking to a prosthetic club, right? So of course we have the restorative digital workflow, which is talking about CAD/CAM restorations from a single unit up to a bridge, usually about 3 to 4 units, right? So you have the chair side digital impressions, right? And then you have basically you're able to scan over to a lab. The lab is able to design that, right, based on the lab software. And you can actually do this in your office too. If you want to do a single day delivery, usually you don't have the time to send it to the lab. You kind of have to do that in your office itself. and you can design the crown and basically mill it inside the office too. As for the traditional model, if you go the complete digital workflow, you can go modelless. You don't have a checkup model. You can just basically do everything digitally. But the downside of that is you don't really know how much you have to adjust chair side when you deliver or try in the crown. So sometimes it's a good idea to kind of have the lab 3D print out a model for you. And that usually costs you about $10 or so, $10 to $15 per model. That replaces the old die system that you have, okay? And it's fairly accurate too. So if you use that to adjust your bite, adjust your occlusion, which shouldn't be needing too much adjustment, but mainly for proximal contact, that's a good way to have a printed model where you can pre-adjust your proximal contact before trying in on patient, thereby saving you some chair side time. Your chair side time is the most expensive time. It's usually, you can quote yourself about $200 an hour. That's where you're gonna charge your patients down the line when you go out to practice, right? So imagine saving about 15 minutes of adjusting a proximal contact. That will save you easily $30 compared to the model that you have. That's worth it, right? And then from the milling side, you can have the lab mill everything for you and finish everything for you, right? The lab usually will have a big scale miller that can mill out everything in pucks. So you can mill out multiple restoration in one go. Or if you want to do same day delivery, you kind of are bound to having your own in-office mill, like a small mill like what we have in the fourth floor lab. That is only able to mill out maybe a bridge, single unit bridge, or not a single unit bridge, single bridge, or single unit restorations, okay? And then you can also have an oven in your own in-house lab, and then basically bake, sinter and crystallize and glaze this thing in your own office if you're doing same day delivery. That's why I was kind of thinking about talking about, you have to choose your right applications. Not everybody is gonna try to go for the same day delivery as a novelty, right? Can you do it? If you have a large scale practice that has a lot of patient demand for a single day delivery, then you will figure out soon enough that maybe it's the time to invest a mill in your office and start adopting that workflow. But if you don't, to start off, I would say a lot of the labs are fairly capable of doing all this milling and designing for you, and then also getting a 3D printed model. So you can start off with by just adopting a traditional workflow, traditional digital workflow, which doesn't involve basically same day delivery, but can still reduce the turnaround time from usually the 3 weeks turnaround time. You can cut it down to almost 1 week or 2 weeks. You of course have to communicate with your lab to set up how that is. Then how expensive is this all going to be, right? So you're going to need an intraoral software, right? And you're going to need lab support, finding a lab that's able to do that, which is not a difficult thing nowadays, right? But you have to may have to try out a few labs before you decide on the one that's really forming a good rapport with you, that works well with you, that's turning out good quality work. And you might need a 3D printer if you want to have models printed out in your own office, or provisional crowns is able to print provisional crowns as well, right? You might want to have a chairside mill if you're doing same day delivery. So scanners, the cheapest one out there is about 30K, up to 50K on the more expensive ones. 3D printer is a lot cheaper, usually $2,000 to $4,000. And the chairside mill is usually 50 to 70K. That's why a lot of times you ask someone outside, how much does it take to start a digital workflow? They will tell you something about 100K. That's basically including the intraoral scanners plus the chairside mill. Another hidden cost, I wouldn't say hidden cost, sometimes there's also a software upkeep. Almost like a office nowadays, there's a subscription model. Every year you have to pay a subscription fee for your own scanner system. Sometimes they charge an upkeep fee. So depending on who your distributor is, who your reseller is, you kind of have to figure that out between you and the reseller and distributor. Sometimes they charge a case by case fee as well. So every case you do, especially for Invisalign, they charge a fee for each case that you do, okay? And then let's talk about implants. All right. So first of all, restoring an implant can completely be done by the traditional restorative digital workflow. Everything is pretty much similar. You just scan in the implant as if you're taking the final impression, and there is a scan body. So that takes place of the impression coping. So you scan in a scan body, and the rest of that, basically the lab can do the work for you to do in terms of design. Okay, so that part is not difficult. We're talking more about implant surgery. So if you're OS or perio, if you're thinking about doing a lot of implants, then there's a guided or navigated implant workflow. So most likely you will need an in-office digital impression, right? And CBCT. And if you're doing this already, most likely you already have a cone beam CT in your office, right? Lab side, you need to have software to do an implant treatment plan for you, right? And then basically they have to superimpose intraoral scanning to the CT scan, which is basically whatever is underneath the gums, all bone structure, to the intraoral scanning that has supragingival structure, all the crown morphology of the teeth. And then basically you can plan your implant accordingly, right? And in that case, you can print out, if you're doing a guided system, you can print out, 3D printed out a digital surgical guide versus the traditional workflow where you take impressions and send it to the lab to fabricate the surgical guide. Now you can just print out the surgical guide, which is a lot cheaper in terms of material costs and time-wise too, okay? And the new thing is called a navigated surgery, which is different from a guided surgery. Guided surgery is basically when you as a surgeon is basically guided by the surgical guide, right? Navigated system is basically almost like a robotic surgery where you have additional controls on your handpiece. So the computer tells you exactly whether or not you're deviating from the surgical plan, right? And then basically telling you that it will actually be, you will encounter a lot more resistance if you're deviating from the original path, insertion path. So when you're drilling along the way, it's gonna show you a lot more information, all right? So how much does that cost us? Again, scanners, not counting the CBCT, which is probably 50 to 100K easily, right? But we're just talking about additional, right? Digital impressions, about 30 to 50K again. Software in the lab, we're not talking about that. Then the guided, if you're going to the navigation system, usually it's about 10 to 15K only. All right. Of course, there's could be software upkeep fee and then everything, but it's not too much. Navigated surgery is really something for people to consider if you're doing a lot of implants. I think it's really good, man. And if you're doing a lot of single unit implants, I think current technology proves that single unit implants navigated surgery is by far more accurate than the traditional guided surgery, right? And it's a lot easier too. You have the little kind of peace of mind that you know you're not going to go too far. Okay, we can definitely go into more details if you're interested. Feel free to email me and ask me about those too. Okay, orthodontic workflow. You guys already know Invisalign, right? So traditionally, Invisalign is only attached to iTero, but nowadays, recently, I think Invisalign is opening up more software scanning systems. I think Medit, which is a Korean company, is allowed is kind of partnering up with Invisalign now, 3Shape too. So essentially what you do is scanning the patient's intraoral conditions and basically send it to the lab. And then the line system, which is part of the Invisalign, will basically figure out the treatment plan for you, all right? And then you just have to approve it and basically make your own modifications in office. That usually takes about within an hour, you should get everything like a treatment plan back. And then basically it will basically churn out the trace in sequence and then basically send it to the patient. All right, so that really streamlines the process and saves the patients a lot of time and encourages the patient to not do those small side, DIY kind of Invisalign or liner system, right? Because it makes it so much easier to go to an orthodontist to do this. Of course, if you're a general dentist who is interested in becoming an Invisalign certified, you can also do this too. So if you already have a scanner in your office, you should have the hardware available. You just need to probably get an additional module to be able to do aligner systems too. Okay, and that's pretty much the cost, right? So in the sense that when the reseller sells you a unit, the software will have different modules and components. For example, the implant module, the aligner module, the DSD, the digital smile design module, those will charge basically a little bit extra. Just like when you buy a car, this is different packages that you're buying. So it's pretty much like that. Okay, software upkeep, case by case fees usually. Okay. Now aesthetic digital workflow, we're talking about digital smile design. Just to share with you a quick kind of a workflow, just so we have a basic understanding. You can take a photo of the patients, right? And usually they will ask for a rest, lip at rest smile, and then also a retracted smile, so that we can see the footage as well. I can basically upload that photo into the software. And for example, 3Shape will have its own digital smile designs module, right? Where you basically can then do your digital smile design based on the patient photo, right? So you overlay this little pattern right here. You can adjust the teeth accordingly to come up with a smile to the patient. And you can show the patient within probably 10, 15 minutes that you can basically click around on your software, upload the patient's photo, click around the software, and then you can show the patients how it's going to look like at the end of the treatment. Of course, this might be a pretty involved treatment based on what the patient's gums line is going to be. For sometimes cases like this might require a little bit more of perio surgery, right? A little bit of crown lengthening in the case, and that could kind of prolong the treatment. But it's a much easier way for you to kind of communicate with the patient, present your case, so that they have a higher likelihood of accepting the case treatment plan. Okay, and then what you can do afterwards, when you have to proceed with aesthetic workflow, with a treatment plan, usually at some point you have to do a mock-up for your patient, right? And traditionally we learn in the preclinical lab, we'll have to do a putty, we have to do a conventional wax up, you have to do a putty from there, and then from the putty you can basically inject your, you can use your integrity material, you can use a composite, and then generate a mock-up that way. But now you can do everything digitally as well. You can have your lab do it if you don't want to do it yourself, right? So all you have to do is scan in the patient's teeth. The lab is able to design a mock-up based on your intraoral scans. And then they can actually superimpose the photo you upload, basically the digital smile design photo, what your ideal smile is going to look like, and overlay that into the 3D wax up. So they can adjust the wax up so that it's perfectly fitting or aligning with your DSD photo. And from there on, they can basically generate a model that has the ideal DSD wax up. And from there, you can 3D print a model and generate that putty stand then. And then you get a putty stand and the model there. And you can basically, when the patient comes the next time, you can use a putty with a little bit of a flowable composite or integrity material, bisacral material. You can basically fabricate a mock-up. And that's not the final crown, of course, but that's a nice mock-up. You can do your veneers, you can do your crown cases, crown preps, and this is going to be your final mock-up. Okay, and something really nice for the patient to appreciate what the final treatment outcome is going to be. Okay. Now, dentures. I know at UCLA we haven't really talked a lot about digital dentures because we are UCLA, we have very particular, our process department has very particular guidelines into what they want in terms of denture setups and whatnot. But a lot of other schools are already doing kind of digital dentures. It's becoming far more popular among the prosthodontists or even general dentists sometimes in outside private practice. So usually the workflow is like this, where you don't scan the patient's arch because we are still having some difficulties scanning edentulous areas. And I will explain a little bit more why that is in the later slides. But usually what they do is you're still taking the conventional impression, final impression. If you need to have a custom tray, you can do a custom tray, but then usually you have to do the traditional conventional impression, pour up the master cast, send it to the lab. That is going to scan in with the lab scanner. So the scanner is much more accurate parasite intraoral scanners. They're much more accurate than our intraoral scanners because it's scanning the model from different angles, rotate the angles from 360 degrees and able to scan. There's almost no dead angles, no blind sides, no blinds. So usually the lab scanner is the most accurate. So they will scan in the cast using the ladder. And then from there, you incorporate that into your digital designing software, right? And then you also send in the wax rooms that you, so that you know basically how of the patient is going to be. So you still need to know how to do wax rooms, right? Scanning the cast with wax rooms, right? So you know the occlusion. And then from there on, the lab is basically the software is going to generate something like this, where you have basically the rooms into occlusal spaces to set the teeth. And you can outline the gingival regions and basically generate some kind of a record base. And have library teeth to select based on the patient's age and gender or characteristics to choose the right type of teeth. All right. And you can also trim the base of the teeth as if you're actually having a burr in your hand. So you can actually set everything here in the software itself. The lab is going to do that if you don't want to do it yourself, of course. Okay. Then you will have two choices. You can mill out the denture using a lab mill usually. None of the chair side mills is able to do this at this point, but you have to use the lab mills, which can generate a base plate and then the teeth, acrylic teeth, and then they will basically glue them together. Or you can do a 3D printed parts, like 3D printed teeth and 3D printed base plates. Usually the milled ones is a little bit sturdier, stronger. But you can do aesthetic trying with a quick set models without two-tone, just single white color 3D printed denture. Do aesthetic trying with your patients to see how they like it. Some people would say that they can skip the aesthetic trying, but I would say a lot of people will actually tell you that a lot of things can go wrong during the aesthetic trying. It's always a good idea to bring the patient back one more time to this aesthetic trying, right? And then you do the final denture delivery. Okay, so again, it's basically traditional impression. Then everything is processed digitally, designed, and then teeth are set digitally, and then you have a 3D printed try-in, and then final denture. If you really compare the dental visits, you have the initial visits to take the final impression. The lab will do basically impression scan. They'll do digital articulation based on your wax rims, set up the teeth, right? And then you approve it, of course, and then they will give you basically a fabricated denture, but also you should have a digital, not a digital, a try-in with a 3D printed denture first, and then final delivery. So that usually about 3 visits for the patients, compared to the conventional methods, where if you go outside, we're not talking about ULA right here, where you have 24-hour check and 1 week check and then everything too. It usually takes about at least 5 visits or so if you don't want to compromise the quality of the patient's dentures, right? So usually at least 5 visits. So that at least saves the patients 2 visits, right? Saves you some time. Okay. Any questions so far? So far, so good. All right, then we'll continue on. So other types of digital applications, we're gonna just quickly glance over it. Some of the softwares, for example, nowadays, they have a patient monitoring system where you can compare the scans patient at different times. For example, if I see the patient every 6 months or so, I scan the patients every 6 months. I know he is going to be a bruxer. I would then be able to compare how the teeth have changed over time. Pick any 2 timelines, compare scans, and be able to see if there's any part of these that are worn down more than usual. That could be a restoration where that could be a tooth, but that's a really good visual tool to your patient. It's time to the night guard. Okay, and of course you can do the occlusal guard or any kind of occlusal appliances and using this digital design software. And all you have to submit is basically intraoral scan, full arch scan to the lab, and take care. They can usually 3D print the appliance for you. Okay, a little bit more futuristic ones, not in practice right now. This machine AI, right, for radiographic and diagnosis, which usually tells you basically give you a better diagnostic tool based on given a particular radiographs, biopsy, or even panoramic X-ray. The software, the algorithms might be able not there's a carries. So as you know, if you have already practiced in the clinic for a little bit, sometimes it's kind of borderline, it's a little bit ambiguous whether or not there's actually a radiology or not, right? So this hopefully is a future in the sense that it will the amount of accuracies and reduce the human errors in terms of diagnosing caries on the X-ray image. But then I will also lay out the challenges with this. For machine learning, you kind of have to put in a large database, right, to train the algorithms to know what are radiolucencies, what are false positives, false negatives. So you need a large database, and when that database concludes, it's not consisting of just X-rays. You kind of also have to come with the diagnosis with it, right? So you actually need to have a group of experts who can diagnose the X-rays for you, and then have the matching database sent to the machine. And that's where this major obstacle is to set up this any machine learning software. However, there is a lot of startup companies that are looking into this. I know there are also companies that are looking into digitally detecting cracks inside the tooth. So any kind of internal cracks, like cracked tooth syndrome, you don't know the extent of the crack until you open up the tooth. So they're trying to figure out ways of using machine learning and whatnot to figure out how far the crack extends based on certain ways of, for example, resonance of certain kind of vibrations you send on the tap onto the tooth. And those are kind of fancy talk for now. They maybe to be in practice in the next 5 to 10 years. But you know, with technology, sometimes things just go a lot faster, proceed a lot faster. They will explode, but sometimes everything gets delayed, right? We talk about stem cell regenerated teeth about 10, 15 years ago, still not the reality now, right? But scanners, they have caught up much faster. So you never know with those, okay? So let's break down your typical workflow in terms of being a dental practice. You start off with planning a treatment, right? Set up a treatment plan. You talk to the patient, communicate with the patient, communicate with the lab to set up what you need, and then execute the plan, basically by performing the treatment, right? So no matter what you do, essentially those are the three steps that you do on the patients. So if you have a digital workflow, how that helps you with the treatment planning is that it's much more streamlined. So you basically models, or you can just see a computer and show the patients in a much faster way how the treatment is going to be. And you kind of also have in your computer a lot of saved cases from other patients without violating HIPAA, show the patient other treatments instead of showing them a model which is not necessarily the most visual, because to us is second nature, but to the patient it's still kind of a foreign object, right? But if you have a photo, patient's face photo, a patient scan that's very personalized for them, it's much easier to accept and visualize. And from their information, because that direct is much easier for them to accept patient treatment plan, especially for large tens of dollar aesthetic cases, right? If you're going to be a prosthodontist who's going to be doing denture cases, removable partial denture cases, multiple teeth, full mouth rehabilitations, those are going to be coming in handy too. If you can show them kind of a full mouth kind of mock-up of how their teeth are going to be beforehand, or even send them an email, that would really increase their case acceptance, right? And you can do flexible and more instant lab communications. You don't have to ship the lab models, impressions, and whatnot. Nowadays, everything is sent out digitally. And it's much easier to communicate with the lab. You can change things along the way and update things. If you need more information, usually it's a little scan, and it's streamlined the process a lot more. And in terms of execution, for patient able to visualize the case progress much better. Let's say you're doing a CAD/CAM case, right? You start off with pre-op scan. They already are wowed by, or basically you're able to show their teeth. They're seeing their scans the first time, and then you prep the teeth. They get to see how the prep tooth is gonna look like without even have to basically. Sometimes when you show the patient how the teeth is gonna look like, or the prep is going to look like, you kind of have to show the patient's mirror. Patient is holding up their own mirror, so you have to hold up your mouse mirror to show the patients how that looks like in the patient mirror, right? So all of that is gone. Now they can visualize the 3D image, and it's much easier, right? And they can see the tentative crown design. So you can send the lab for the final design, but always do a simple crown design in 3 to 5 minutes, right? The patient can see your tentative crown design, have an idea how the final crown is going to look like, right? They will be impressed by you. Patient comfort, there's no more glue material in terms of the impression material, traditional impression material. So patient comfort is better. And reduced number of visits. Why is reduced number of visits? We talked about for digital dentures, for example, that reduces patient's number of visits, but also for your crown bridges cases, the number of redos also drastically goes down because you get to evaluate your preparation right there and then. Instead of having to send to the lab and the lab send the case back and telling you don't have enough occlusal reduction, you don't have a clear margin. You can see that right away on your scan. You can evaluate the distance of interocclusal distance right away. You can basically make your adjustments and modify your scan right there. So that's to reduce, drastically reduce the number of retakes you have to do, reduce the patient's number of visits there, right? So we talk about reduce, improve turnaround time. So if your patient has to get out of town for a wedding or something in the next week, can't wait the 3 weeks, right? This allows you to deliver something much faster, right? Reduce material costs. You don't have to basically use the impression materials anymore, right? That saves your material costs. And then shipping costs, sending into the lab the cases and reduces the cost too, right? Overall, it's patient comfort. We always place patient first, right? Patient comfort, patient confidence in the case all gets improved, right? Case acceptance rates goes higher. Saving cost in terms of your time cost and material costs, increase revenue because higher acceptance rates, lower costs overall, right? So let's go into that a little bit more. When we say reduce costs, let's talk numbers. If you're assuming about 20 crowns per month, you're doing 20 crowns per month. Material cost is about $15 per case for impressions, and maybe include shipping in there too, right? Assuming the lab charges you the same cost for whether they're going for the conventional workflow or digital workflow, usually they charge you the same fees. Let's say you have a 3% to 5% remake rate, right? Because of the poor impressions and whatever reasons with a traditional workflow, right? There's a calculator that shows you that you can save up to $3,500 every month. 17 hours freed up. Why do we break that down? Basically, impression materials with impression digital work, you almost don't have any impression materials costs anymore. Shipping is a little bit cheaper too. Fewer remakes, right? Considering your chair time, right? And your own dentist time because less number of remakes, redos, and then your assistant's time too. Because every single time the patient is in the chair is costing you and your assistant at the same time. Of course, you're going to cost 8 times more than your assistant, but that's money, right? So adding up, that really adds up to, if you're talking about $3,500 just from prompts alone, add in more other applications you're going to put in your practice, right? It's going to add up for quite a bit at the end of the year. Now, increased case acceptance. We haven't really talked about increased case acceptance, But talk about having a digital smile design, having the patient being able to visualize the outcome right away, and that probably will increase your patient acceptance rate a little bit higher, right? And that imagine them visualizing the tooth wear, maybe they're starting to become more amenable to a occlusal guard, right? So all of those things will become a percentage of your gross profit too, right? Let's say another 15% of the case acceptance. Add that 15% to your gross revenue, right? And that's the cost we didn't even talk about in the cost savings. And you're saving up all those time from the redos that you didn't have to do again. Now you can reinvest that time to do those additional cases in your service practice, right? So overall, let's say adoption of the labs already ready, right? So comparing, this is data from one of the big dental labs, Rodenberger, and it's showing you 2015, about 15% of labs are adopting basically 3D printers. That almost doubled in 2019, probably even higher at this point, right? Labs adopting digital design software is about 50%, 50 to 60% nowadays. Much more, it's only gonna go up as we go, right? A lot of the big labs that will have a conventional analog workflow section, and they'll also have a digital section. The digital section is basically a bunch of computers, a lot of like youngsters sitting in front of the computer and trying to design crowns and appliances and bridges and restorations that way. It's a much lower cost, much lower turnaround. And the percent of labs that are using CAD/CAM systems is around the same. Usually, if you're already adopting the digital design software, most likely you're doing CAD/CAM as well. Okay, so the labs are pretty much already ready in terms of 50 to 60%. The dental offices, I will usually say about 30% of the office, if I'm being optimistic, is about 30% of the offices out there are doing digital workflow, right? That number is probably going to increase more, right? And impact on your dental workflow, as we kind of talked about already, is going to generate more precise, effective, and personalized treatment, strengthen your ability to kind of differentiate yourself from other practices, right? Especially for the higher end treatment. Full mouth rehab, aesthetic cases, that's going to really have your practice stand out if you're adopting a digital workflow, right? And the lower need for rework and perceived quality of the treatment is also better because your patient is wowed by you by all this new technology, right? Lab cost reductions is going to partially transfer to you as well because the time cost of the lab reduces. Lab loves it when you do a digital workflow, and eventually it's going to reflect in certain parts on your lab fees as well. Okay, time savings. I think that's a big part because the number of redos, the number of reduced production time, all of those things will increase the patient satisfaction and then also free up some of your time, chairside time, to do other things to provide better care. Okay, so I'm sure at this point you're already jumping like kind of let's go digital, let's go digital. Is there any kind of caveats? Yes, there are limitations, right? There is always initial investment, learning curve, right? When we're talking about $100,000 purchase, that's a big purchase. You kind of have to think about that twice, especially you were setting up a new practice. It's kind of difficult in the first couple of years trying to commit to that. And after especially buying a new practice and starting to balance your books, and then maybe thinking about getting implants and whatnot in your practice and expanding your scope, and then maybe thinking about digital. But I was encouraged to start thinking about that a little bit earlier. Maybe start thinking about adopting a digital workflow from the start, getting a scanner in your office first, and try to expand on your applications as you go, right? You can always start with a CAD/CAM workflow. As we shown you earlier, it probably takes about 8 months to a year for you to break even. And after that, you're gonna make money, right? In terms of personnel and lab support, you need to find a lab that is going to work well with you. And you have to train your lab personnel to do the scanning. Most likely it's not gonna be the dentist who is gonna do the scans, especially if you're talking about orthodontics workflow. But for your final impressions, you might want to scan it yourself. But for all the pre-op scans, the intraoral scans, or periodic exam, the routine scans, your assistant should be able to do it. You have to train it to do that. Scanning does not work in every scenario, and we'll talk about that a little bit more, right? So monetary and time investment, 50 to 100K initial financial investment could be a lot if you're just starting off. Software upkeep and subscription costs, you have to look into that with your resellers and talk about that. It could add up too. CE courses and training of the personnel could be a financial and time investment as well. And then may take up to 1 year for you to break even before you start making any money back, right? Taking those into consideration. Now, scanning itself, as we talked about, is not necessarily there for every single case. So edentulous areas is one of the major areas where the scanning is still is kind of still challenged in terms of scanning any kind of edentulous areas. It doesn't have to be fully edentulous, just as, for example, you have 2 teeth and missing 1 tooth right here. That edentulous area sometimes would just give you a lot of skipping when you're trying to scan the area. The reason for that is basically because there's no tooth, no hard tissue, no features for it to recognize. It's so easy to recognize posterior occlusal because you have all the dental anatomy. But when you're talking about a mucosal surface, it's an elastic, movable surface. Along with the mucosa, you have all the tissue movement as well, the tissue displacement. Every single time, you can't have the patient hold still the whole time. They're going to move their mouth. Every single time they move their mouth, the tissue is going to move slightly. It's going to change. So that introduces more inaccuracies there. That's why it's so difficult for the scanner to recognize. So they're coming up with ways to tackle that problem. For example, you can use eugenol cement to kind of mark the palate for the patient, so that it's almost making a landmark on the patient's palate. So that makes it a little bit easier to scan your full edentulous arch. And then for anything that's longer than 4-unit span, the accuracy of the scanner drops down. This is a little study that shows different kind of scans. Those are going to be new scanners, like Prime Scan, which is the most common, most up-to-date CEREC scanner, the Trios 4, right? Carestream, Medit, which is the Korean scanner. Those are all good scanners, right? When you compare the kind of basically anything that's green is showing you that's basically within a reasonable discrepancy compared to the actual lab model. But you can see that towards the distal part of the tooth, you're starting to see a little bit more yellow, right? Starting to see a lot more yellow towards the distal part of the tooth. The reason for those is because as you add up the scans, each scan is basically you're taking an image and you're stitching the image together into basically a video cord. And as you stitch them up, the arrows is going to add up as you go towards the end of the arch. So you're going to see a lot more arrows towards the end of the arch. They all accumulate towards the distal portion, the second molar, third molar area. And then they also tend to kind of, because of the fracture of the teeth, they also add up more on the buccal side of the teeth too. So that's why we say that you usually don't do cross arch applications or scannings for, if you're doing 2 restorations, you might as well just scan 2 separate quadrants instead of scanning the whole arch. If you're doing an appliance, that doesn't matter as much because the fit you can adjust later on. For restorations, because every single micron counts, you kind of have to do basically single quadrants instead of cross arch scanning. Same thing for implants. If you're doing implant surgeries, if you're not doing single unit, you're doing cross arch, you might want to do that separately. Okay. Now, we're not talking about scanning challenges anymore, not limitations anymore. This is challenges. Challenges means that something that you can, it's more because the operator errors, operator control has more control over this, in the sense that if the patient has an irregular bite, it sometimes makes it difficult because the patient can have a cross bite. The bite might not be stable when you take the bite scan. All those things can lead to errors in the final scan. So you want to make sure that you establish the patient's true bite, do a few practice runs with the scanner in and with the scanner out, have them actually bite down on their back teeth or bite into their quote-unquote MIP position, their habitual bite position, and reproduce that a few times before you do the actual scanning. and then ensure that you have at least 4 teeth on each side to make sure you have enough information for the lab. Basically, the bite scan is just the buccal scan, contour scan, where it's basically superimposing all the upper and lower arch scans onto that buccal contour. So the more teeth you have, the more accurate it's going to be. And then after you take the bite scan, verify that bite scan against the patient bite using some intercuspation landmarks. For example, I can use the distal buccal cusp against the buccal groove right here. I want to verify that's the same intercuspation in the patient's bite. Okay, those are tricks that you can ensure that you have an accurate bite registration. Moisture distortions. It is even more important for you to isolate the tooth to keep it dry when you're scanning, right? So if you have moisture, it's going to distort your image, especially if you have a margin that's slightly subgingival. So what do? Double chord technique if you can. All right, instead of double zero chord, use a size 0 chord to get a little bit more separation from the gums. And you try to bury that chord, make sure the chord stays buried in here. If you don't have enough pocket depth, you might not be able to do the double chord technique. Then we'll still ask you to do a large single number 1 chord and make sure the tooth is dry. If there's bleeding, make sure you use hemostatic agents. Wait for that 5-10 minutes. Don't rush the case. Wait for the 5-10 minutes. Make sure that it's completely, the bleeding completely stops before you proceed to the next part. And dry isolate, get an assistant to help you if you're doing this in school, all right? Use cotton rolls on the lingual side of the vestibule and everything too, okay? What do you think about scanning with the rubber dam on? That's a very good question. So depending on what you're trying to do, if you're scanning with the rubber dam on, you're still able to visualize the margin, I would recommend that because you can add on the image, because we talked about scanning we kind of talked about scanning the pre-op scan. So you can add on a certain portion of the margins just using use a rubber dam to scan in the tooth that you're prepping, and then take off the rubber dam and scan in the adjacent contours. You can do that. So it's a trick that if you want to discover it, basically you can try that too, all right? But a lot of times I would say that most people don't scan in with the rubber dam online unless you're making a inlay or onlay prep where you have everything super gingival, but most of our crown preps is kind of equigingival or subgingival, where after you place the rubber dam, it's kind of hard to see the margins. Now, subgingival margins, we're just talking about that, right? So if you have a subgingival margin, can you still scan? The answer varies. So compared to the conventional impression, where the impression material is able to push into the sulcus a little bit, flow into the sulcus a little bit, expand the gingival a little bit away from the tooth margins, you don't really get that with the digital scanning, right? All of this is depending on how well you can pack the cord. So studies have shown that if you have a really submarginal gingival margin that's about 1.5 millimeter, you're going to get a lot more deviations from the actual conventional workflow generated cast. So there is going to be a little bit deviation there, about 0.5 millimeter, which is quite a bit, right? And then now if you're looking at deep margins, more than 1.5 millimeters, that's almost 1 millimeter of differentiation. And that's a lot, that's too much, that's clinically not acceptable. Right, and there's also region specific in the sense that location specific of the tooth. On the straight mesial and straight distal is where you tend to have more arrows. Of course, those are areas that's difficult for the scanner to capture in the first phase. So it's also tend to be an area where you tend to have more discrepancies. So think about where you have the deep margins. After the cord isolation, if your margin line is more than 0.5 millimeter subgingival, and you can't really visualize that margin on the mirror after you take out the cord. If you can't see it on a mouth mirror clearly with a little bit of the tooth next to it, like basically a little bit of emergence profile next to it, just abort the digital impression. Take the traditional PVS impression, but you can still send it to the lab and ask them to go with the digital workflow. Why is that? They can scan in, they can use the lab scanner to scan in your PVS impression. That's what they are already doing for a lot of your conventional cases. The scanning the PVS impression, they design the crowns that way. You can tell them to go to digital workflow. I just need to see a 3D printed model, or I can go modelless if I want to, all right? And then just do everything digitally. You can do that still, all right? Digital workflow. So don't be afraid to go the traditional route. The PVS is still our go-to when the scanning don't work, okay? So what's next? What's the game plan for us going forward, right? Let me see, there's a new question here. Do you need a conventional chamfer or shoulder termination lines, or you can also, what's a BOPT technique? Can you spell out the BOPT? I'm not familiar with the acronym. Yeah. And then for the first part of the question, usually I would say nowadays with the digital scan, if you're scanning the crown, usually we're going with a shoulder margin, most likely. If you're having a super gingival margin with a chamfer, you can still do it. But since it's usually all ceramic crowns, restorations, usually we do a shoulder margin all around. Or deep chamfer. And you try to have a, yes, you do need to have kind of a margin finish line. Biological oriented or vertical prep. Yeah, so if you're talking about kind of a feather edge or marginless kind of prep, I would suggest not to do that, because you want to have a more definitive termination line. It's so much easier for the lab to recognize it, unless you know exactly where your margin is. In that case, I think we prefer it that way. At least at UCLA, that's how we proceed. And I know there's a school of thought of whether or not we can go the marginless crown preparation and go the feather edge way, and then just basically kind of hide the margins that way, and then have the crown lab design the crown that way. But that's usually what we don't. That's not what we do here, at least at UCLA, or a lot of the common practices at this point. So we still encourage our students to have a very definitive margin finish line. And another thing right here is that on the crown margins, you can actually mark your margins. You can actually mark your margins on the impression. And that information gets transmitted to the lab. So the lab knows exactly where you want the margins to be. If you have an ambiguous part of the margin, you can mark that margin and send it to the lab and make an annotation, make a comment, so they know to look for that margins exactly where you want it to be. So it takes the guesswork out of it.
And also for preps, those margins, it's can't really mill those restorations clearly, right? Because margins are going to be feather edge and it's not going to mill properly. You would have to press those kind of restorations.
Yeah, that really depends on the kind of the design, right? So when they do those kind of chamfers, very narrow chamfers, for zirconia, for Emax, that usually becomes a problem. But we are able to mill restorations in other materials too. You can mill the crowns in metals too. And you can do PFM crowns with those milling as well. Yeah. Okay, so let me start with a quote. Education is the most powerful weapon which you can use to change the world, by Mandela. So we should start with the school, right? Your journey to adopt a digital workflow should start at UCLA here. And you guys have already done this in the preclinical stage. Now let's talk about what we're gonna do in the clinical stage, the IDDS clinic, right? A quick overview of the workflow itself. You want to, if you have already done a crown case on a patient with the traditional workflow on your own, we're not talking about second, fourth year crowns, we're talking about on your own, right? So you know the traditional workflow one time. Then talk to us if you have a crown case. We're gonna do a pre-op case evaluation, we're going to need some kind of information based on the intraoral photos of the patient. We need to see the patient's cast. You're going to need that no matter what, no matter if you're doing a conventional workflow or the digital workflow. You need to have your cast, you need to have your stents and everything ready, right? So show us a cast or a photo of the cast. Have a little consultation with me or Dr. Khalifa. Usually those goes fairly fast. We'll talk about material choices. We'll talk about the timeline. EMAX, we're able to do same-day delivery. We can also do a 7-day turnaround. Zirconia crown, zirconia crowns, we can do a 7-day turnaround, meaning that the next week the patient can come back, we can get the restoration for the patient. Case limitations, usually at this point, I think we're only doing full coverage restorations. We're doing onlays, inlays too, on a case-by-case basis. But so basically just show us a case. Don't think about limitations yet. Just show us a case. We'll tell you whether or not we're comfortable doing that digitally. And if we're not changing videos or anything, then it should be fairly straightforward. And we'll also take a look at existing restoration to see any other kind of clinical considerations you need to have. Whether or not it's likely for us to achieve a supergingival margin, right? All those things are things we need to consider, and then plan out the timeline when you want to schedule the patient, who is going to cover you and everything. Once we have that figured out, you're going to schedule with your GPA. On a Thursday, right now, we are only doing Thursdays. There's an IDDS clinic, which is the second floor. And you're going to have a one-to-one faculty to student ratio usually at this point, right? It's really pampered down there. Your faculty is going to assist for you too sometimes, right? Then for the appointment itself, we're going to try to do everything in that clinic, in the sense that we're going to try to do the preparation too. If you're really fast on the preparation, we might be able to do the scanning at the same appointment too, okay? And once we scan in the appointment, right? So it's not like you also have to have the patient crowns already prepped. You can just come in with a brand new tooth and then start preparation. If you don't finish the preparation, we're just not gonna go to the scan. We're just gonna bring you back on the next week and then do the scan, all right? So you still need to provisionalize the patient, okay? Even if it's for same-day delivery, we still want you to learn how to do provisional correctly, all right? So we're gonna still ask you to provisionalize. And the second or third appointment is going to be the delivery, try-in and delivery. So in between the scan, let me talk you through the workflow a little bit, and we're going to show you the cases too. So once you have sit the patient down, numb the patient, you're going to take a pre-op scan, which helps you kind of get an overall contour of the teeth scanned in, so you don't have to worry about scanning the patient after the patient is already tired after the preparation. After the preparation, all you have to focus on is one thing, that is the tooth that you prepared, right? Only for your final impression, only focus on one tooth. And that's a lot easier. And then prep the tooth, everything is okay, and then pack the cord, and then we're gonna scan. After we scan, make sure the scan is good. We're going to, the faculty is gonna help you in terms of evaluating your prep to see whether or not you have enough reduction or not. If everything checks out, we don't need to change anything. If we need to modify a little bit, we rescan the teeth, okay? And after that, the faculty is gonna basically go on the side and start, while you're basically preparing for the provisionalization, the faculty is gonna do a tentative crown design to make sure that your crown is going to be okay. Sometimes we see the occlusal clearance is good, but when we actually design the crown, we realize it's a little bit short. So we're gonna just design the crown tentatively, and the patient is able to see that too before they go. So that's also the nice thing. And we're gonna mark the margins. We're gonna send it to the lab, so the lab knows exactly where we want the margins, right? And everything else happens between your restorative faculty and the lab, which is right now manned by the advanced pros faculty, Dr. Danny Chow, right? They're gonna do the design and milling and the finishing too for us, okay? I will highly recommend for you to bring a student assistant for you. That will help the process along a lot faster. So a lot of times when you need to grab something extra, it's best to send your assistant over instead of you running around, okay? And then bring a DSLR camera because we need to take pictures along the way, okay? And then after the delivery, we're gonna take post-ops documentation. We have the PowerPoint template online. You just need to download that PowerPoint template, insert your photos and scans into that into the PowerPoint, submit it onto CCLE. And once we see the case submission, we are able to give you the RVUs necessary for the case. Okay, and then coming soon is when we're also gonna have patients, student satisfaction surveys to see whether or not you learn anything, you appreciate this, you like this digital workflow a little bit more than the conventional workflow, and all of those things, so that something for us to learn, for us to grow as well. Okay. Any questions at this point before we show you some cases? All right. So we have a few cases done by the students so far. I mean, before we launched this IDDS clinic, I already kind of tried it with before COVID starts. We tried like about 10 to 13 cases, I believe, in the clinic. But this is actually after the official launch of the clinic this quarter. We have done about 4 cases so far. We have a 5th one probably towards the end of the quarter. So Alexa and Fernanda did a case together on 1 patient. We did 2 crowns, right? So they have already had the crowns prepped beforehand. So this is the pre-op photos. So, and the crown this is number 2 right here. It's already provisionalized. The reason we asked for a Model Z crown is because the patient is a grinder, some tooth wear on the other teeth you can see here. And
what's up?
And this is the bite wing photo of the tooth beforehand, the large amalgam before, and everything is replaced by the buildup, and then now this is a prep, right? It's far off in the mouth, so we couldn't really see the prep very well, but you can see that much better on the scan, I promise you. Okay, shade selection, the patient wanted the brightest shade possible. He doesn't really care if it's all the way in the back of his mouth. They had a lot of difficulty trying to capture the impression, traditional impression on this patient too, because the fatty cheek, patients really hard to kind of maneuver around the patients with the soft tissue management. So they decided to do the scanning instead. Okay, so we scan in. This is the pre-op scan. You can see those are provisionals. And then this is a little image of the final prep. And you can do sometimes I prefer if you have a screen recording of the final prep, right? So they can see it 360 degrees, see how that prep is like. Okay. It's not an ideal prep, right? But at that point, I couldn't really do anything to it, just making sure it works. And we decided to bond this restoration because it's a short axial wall, it's a short restoration. We were able to bond this zirconia restoration too. Right, if you already don't know, you're gonna hear from us soon that we're also coming up with bonding protocols for zirconia restoration too. For short crowns like this, it's best to kind of go ahead and bond it. Okay, so that's our crown prep. Okay, photos of that. And that's a restoration from the lab, right? That took about 7 days. 7 days turnaround. Next week we had that. Trying it straight from the lab without any adjustment, you can see certain parts of that. That's heavy excursive marks, distal buccal and oblique ridge. And so we adjusted it, and then that's the final restoration after delivery. Okay, after the bonding of the restoration. On the 15th, I'm gonna go a little faster, a little bit ocular provisional. Also, I'm basically opposing a partial denture. Right, so you're able to scan it in. Traditionally, you have to do a full arch scan, but for this digital scan, because the bite of the patient doesn't move, you can do a quadrant scan. That's totally fine. Okay, as a pre-op X-rays, this is the preparation with a cord in. As you can see, a single cord in there already, double cord already buried in there with a number 1 cord showing up. Okay, so the buccal view, because it's so far back there, soft tissue management was really a challenge with this patient, so we weren't able to get a really nice photos, but same shade selection is installed. So for this case, since 2 crowns were both prepped, so we had the 2 students in there, we scanned both teeth in 1 appointment, delivered both teeth in 1 appointment. So the patient got both teeth done in 2 appointments, all right? So occlusal view, buccal view of the scan, occlusal view of the final, that's a pre-op scan. This is the final prep scan, all right? And then you have the tentative design. So you can actually tentatively design the crown And then basically you can see the green line right here. That's the margin I marked for the lab. So I can send it to the lab and show the lab, this is the margin I want, because actually the lab had a lot of questions on some of the margins were a little bit iffy too. Okay, so then you're able to do this. So can you do the crown prep before and book the appointment with you for the scanning? Yes, you can. We prefer that you do the prep in our section because we have better control of where you put the margins, where you leave the margins. All right, so we have better quality control in that sense. And just in case everything goes all right, then we know right away, maybe this is not a scanning case, everything is subgingival already. Maybe we know right away, this is not a scanning appropriate case. And then we can basically plan for the PVS impression instead. Okay, so we prefer if you can do the scanning to the preparation also in the IDDS clinic as well. And it gives you the flexibility if you do everything fast, finish everything fast. Of course, you want to ensure quality too, but it gives you the flexibility of doing the scanning in the same appointment too, for those people who are a little bit faster, right? Now, that's the final tentative design, the final restoration, try in without adjustment. After adjustments, you can see it, we basically eliminate the most of the marks. And then basically that's the final restoration, okay? Now, we do have a same-day delivery. Ava was working on her mom, came in here 31. You can see a large amalgam buildup pre-op, right? And on the lingual side, that's the CAS photos. We want to see those on the pre-op, especially on the pre-case, pre-op kind of consultation with us. We want to see those x-rays too. And then we'll ask, after we take off the temporary crown, the crown is kind of, we actually had a buildup already done at that time. So when we start the case, we had a buildup. So we prepped the tooth at that appointment. So those are 2 pins, I believe, from the before on the amalgam restoration. So the buildup was already done. So we just basically did the preparation, all right? And everything was super gingival, so it's pretty straightforward shade selection, decided on the A3 shade. And pre-op scans, you can see this is the pre-op scan and final impression of the crown prep. When you submit the photos later on, please also give me when you do the final prep tooth, zoom in on the tooth, please. Zoom in on the tooth so you can see a little bit better, okay? Ideally, you do a screenshot of the video too, okay? And the provisional, not the best provisional, of course, but the patient is coming back in the afternoon. So I guess for a couple of hours so we can buy that time. And then this is the restoration, come back from the lab in the afternoon at around 2 o'clock, 2:30 or 3. And this is the try-in. Ideally, it's a little bit drier. And the color match is pretty good too, right? If you move the margin a little bit further down, it will be even better. But now, I mean, it's a pretty nice restoration for a same-day delivery. Okay, can we do better? Yes, we can probably stain the tooth a little bit yellower in the gingival third if you can. Can you do chair-side staining in the IDDS clinic? Yes, we do offer that as well. So if you try and you realize the stain is a little bit off, you can do chair-side staining. That takes another 30 minutes or so for you to fire up the oven and stain it and just glaze it too. Okay. Any questions about IDDS clinic before we go to the next part and the final part too? For pre-grade school, what's a pre-grade school?
Doctor, I just have a general question. Do you have to update these like hardware, software pretty often with these like 3D scanners, or are people keeping the same scanners from like way back when?
It's like a Tesla. Some of the things are basically software updates over there, and then you can just download it. And it's more like modules, whatever modules you purchase and everything. It's that makes a difference. But the hardware usually is good, just like a car. Like 5 years or so is no problem. And at some point, you might have heard a lot of people that basically downgrade the old scanners into a treatment planning room to a hygiene room, and then buy a new scanner that way. So you don't waste that scanner altogether. You can still dedicate it for like basically a hygienist every single time when they do the exams and kind of an exam check, hygiene check, and they can do a scanning too for the patient. And that still give you the benefit of potential elements of basically seeing the treatment progress and also potentially looking for tooth burn and everything like that, right?
Okay.
Yeah. Will the video be uploaded? Which video? Uploaded for CCLE so that we can refer to it later. Which video? This one? Yeah, I can put this up on CCLE. I can put this lecture on CCLE under the IDDS clinic tab. Yeah, I can do this too. Yeah. And then yeah, Don is gonna upload the lecture itself. Okay. And I'm still trying to figure out what that pre-grade school means for that. And then, I mean, feel free to talk to me and email me afterwards too. And I will leave my email address in the end. How do I get better after a graduation, right? So let's say you graduate, we're talking about graduating from dental school, not just dental school, from your postgraduate training too, because if you go to specialty, you're gonna get more training in those aspects as well. You're gonna get more exposure too. Find a local study club. That's tend to be most economical option here, because usually they organize those local study clubs, and then you have people who are interested in digital dentistry. You have people to ask, peers to ask, or find a mentor in the area to kind of ask along all your questions. And that's a lot cheaper than signing up for a CE course, right? All your day-to-day operations, you can have someone to chat around and chat about, and so someone to follow your footprints. And it's also a good way to, usually the study club will invite outside speakers to talk about certain things, and that's also a good way. This is pretty much like the Pro Study Club right now, but on the more adult level, grown-up level. All right, now take a CE course, right? Take a CE course, aim for quality. Don't go for those cheap 2-day kind of cheap courses. Sometimes don't teach you a ton of things. It's mainly for the kind of the vendors to kind of market their products. Don't go for those. Go for one of the more reputable institutes, and go to conferences. Reputable conferences, usually they have good CE courses there too. Okay, talk to the company reps at the course. If you have a company reps at the course, you know the big companies already. So talk to them at the course and then basically figure out what your game plan is going to be. And try before you buy, ask for a demo always. Go to the trade shows. If you're really shopping for a product, try all the different things that you have available. Try the new things. Usually they have the newer, latest generation of products available. And you can try the older ones too. Ask for a demo, ask for whatever demo unit they might have, and then try it out before you buy anything, right? And then keep up. It's a newer technology that's changing every day. So you kind of have to go kind of Google, YouTube, and there's a lot of resources that you can look up. Literature review is also good. If you look at the papers, and just like buying a new appliance or buying a new car, you kind of have to do your research. And then afterwards, you can also find out new ways of doing things too. So it's not just stopping, the learning doesn't stop at the point where you purchase the product. It happens all the way through as you continue to use the product and learn new things about it, learn new ways to apply that product. Okay, so that kind of concludes my little presentation, and my little plug is come to an IDDS case with me. Every single time I'm running to the third year and fourth year, they say they miss me, and now is their time to work with me together. All right, I miss you guys too, and hopefully we get to work on a case together soon. All right, and no, any questions? Happy to entertain.
I just have a question. Do people do a lot of aesthetic cases with the printers?
Depends. The higher end ones, if you sign up for a lot of CE courses, then you want to do the digital workflow, I think it's a really good idea.